My name is Lalit Verma. I am from Delhi, New India. At the outset, let me invite all of you to this conference which we are hosting in New Delhi. That is Asia Pacific Academy of Ophthalmology, which is a very large meeting, and more than 10,000 people are expected to attend this. So I'll be happy in case. I know there are visa issues, but we can still try. So we'll be talking something about submacular hemorrhage. Although I was not supposed to give this talk, but I have some videos with me. I thought I will share with you. Submacular hemorrhage can occur in various conditions, and the commonest condition which I face in my practice is. Is there some issue? वो दरवाज़ा पीछे वाला बंद कर दे. So the commonest thing which I encounter in my practice is IPCV, idiopathic polypoidal choroidal vasculopathy, followed by RAM, that is retinal artery macular aneurysm. Other causes include trauma or ARMD also. So at the outset, for comprehensive ophthalmology, this slide I made yesterday only, that any macular hemorrhage should not be treated similarly. So one should always study the relationship of blood vessel compared to the hemorrhage. If you can see the blood vessel, then it's a emergency situation. If you can't, that means a subhyaloid hemorrhage that can wait. It can resolve spontaneously, or you can do sometimes laser at the tip of that, or sometimes you can do vitrectomy. But if the hemorrhage is deeper to blood vessel, it is one of the ocular emergencies. And the reason I say it's emergencies, it should be tackled within few days. Otherwise, you have lost the battle. The reason being that iron is toxic. Plus, main reason I think is the contracting clot. Remember this hemorrhage is amongst the photoreceptor area, above the RP, but below the photoreceptors. So any blood there with fibrin will contract, and once the fibrin contracts, all the photoreceptors, rods and cones, they will get amalgamated, and you may not have recovery. So therefore, I say this is one of the ophthalmic emergencies. Although CRA block and expulsive hemorrhage or anophthalmitis, they are emergencies, but this also is urgency. You can't tell the patient, okay, we'll see, come after a few days. And as I said, if it is subfoveal in location left alone, it will have irreversible damage to the photoreceptors. So I'll describe 2-3 case scenarios from my practice. One is this small, thin subretinal hemorrhage, very close to the macular area. In situations like this, this is the corresponding OCT of the same patient. In this patient, only anti-VEGF inhibitors may work. And this is one patient who received only one injection and result was pretty good. And this is the timeline of the OCT. The lower one is the pre-injection of anti-VEGF, and this is the after anti-VEGF injection, showing the anatomical as well as visual recovery. This is another patient presented with 6/36 vision, and you see on the right side the corresponding OCT here. After this first injection, patient had good OCT response as well as anatomical. Patient did receive another injection of anti-VEGF, and this patient recovered from 6/36 to 6/9 after 2 injections. So meaning thereby that small, thin submacular hemorrhage, you need not do heroic measures. So simple anti-VEGF injections will work. This is the third patient who presented with 6/60 vision. He had, this is the RPED, and you notice this amalgam of blood here. And you see after second 2 injections, this patient recovered 6/24. So this was scenario number 1, where the hemorrhage is thin and small in extent. Scenario number 2 is something like this. This is comparatively larger hemorrhage. In such patient, what normally I prefer is pneumodisplacement, that we inject gas in the vitreous cavity. Aim of gas is to displace the blood from the important macular area to an unimportant area in the lower down area. But again, anti-VEGF have to be given, because the pneumo job is to mechanically displace the hemorrhage. Pneumo does not treat the cause, so it has always to be combined with anti-VEGF. So this is one patient who presented finger counting, so 0.3 cc of C3F8 under topical anesthesia, and this is the bubble here. And you see after day 1 itself, could see the blood lowering down in the lower part. And after day 5, with the air, the gas bubble still there, vision did improve to 6 by 24. So after the blood got displaced, we repeated the angiography and found some focal areas of leakage and then lasered this area. So this is important because pneumo does only a mechanical job. Then you have to repeat the FA on ICG, and depending on the findings of FA ICG, then you treat. But anti-VEGF agents are part and parcel of this treatment. So this was at presentation, and this was after 2 weeks of gas injection. This another patient, highly myope lady actually. Right eye, you see this big scar. Any patient who presents with large submacular hemorrhage, suspicion goes for PCV kind of pathology. And this patient also received 0.3 cc of C3F8 and left eye, and this was the fundus picture. And this was the corresponding OCT. This was at presentation. You can see a huge PED, and gradually this PED has resolved at a couple of weeks of follow-up. So pneumo displacement of a moderate sized submacular hemorrhage does work. It's a cost-effective technique because it does not require vitreous surgery. But as I said, it should be done as early as possible so as to protect the neosensory retina from damaging effect of the contracting clot. So the last scenario is a hemorrhage like this. This is a massive kind of subretinal hemorrhage, submacular hemorrhage. So this, I said, is a kind of emergency, and this patient, presented to us with a history of 2 days. We did an FA-ICG. FA-ICG did show some degree of polyp and this BVN, which was leaking here. Left eye, FA and ICG was within normal limits. So what we did was this vitreous surgery. We did a 25 gauge 3-port pars-plana vitrectomy, and aim was to separate the hyaloid from the surface of retina. And for this, generally after the core vitrectomy, you inject some crystals of undiluted triamcinolone. This is the triamcinolone which has been injected here, and aim is to peel the hyaloid from the surface of the retina. And once this hyaloid gets peeled away as far as possible, then you take this dual bore needle. This dual bore needle is 25 gauge at one end and 41 gauge at the lower end, and this is loaded with the recombinant human plasminogen activator. You inject at multiple places. One injection may not suffice because these bloods are loculated. So we are injecting at another place here. So there are various ways of injecting. One is mechanically with the help of syringe. Other automated syringes also are available, which can be connected to the Constellation machine, and then you can inject. So after you've injected at 2-3 places, then you do air fluid exchange, and then that is the virtually end of this surgery. And this is the patient, same patient where pre-operatively this was the picture of the color photograph and this was the OCT. And you see one day itself shows some kind of change. And after serial follow-up, this was this year itself in the month of March. And you see this is the picture, foveal contour has started recovering here. And this is the final follow-up of this patient, same patient. If you see left eye here, right eye, so right eye here, then this is the final follow-up, which patient recovered to 6 by 18 vision from a vision of finger counting. So this is another patient. He is a medical professional. He presented with no glow in the right eye. Left eye was unremarkable, but on the ultrasound we could see some elevation in the macular area, which raised the suspicion of something in the macular area, although we are not very sure what is going to happen. But this patient was taken up for vitreous surgery, and you do a 3-port pars-plana vitrectomy, do a core vitrectomy, and immediately as soon as this gel hemorrhage was taken care of by the machine cutter, you could see large mounds of subretinal blood here. All along the posterior pole, you can see this dark colored blood, dark red blood. But first aim is to remove this gel hemorrhage, which was causing no glow in this patient. And once this is taken care of, try to do as much dissection, but we can't, do base dissection. So then what you do is same dual bore needle, and you have to puncture at multiple places. RTPA. This is showing that dual bore needle 41 at one end and 23 at the other end. So sometimes you can color it with fluorescein or BBG also, just to see the flow. Otherwise, this flow may not be visible, how much are you injecting. And then you do airflow exchange. So this was, day one of this patient, and this is the final recovery of this patient. Fortunately, this patient, because the macula was very good and the disc was very good, this patient recovered 6/6 vision from virtually hand motions vision. So this is the timeline of this same doctor who presented like this, and finally this recovery like this. So again, just to emphasize, all macular hemorrhages are not the same. You have to see whether it is subretinal or subhyaloid. Subretinal demands immediate kind of intervention. Subhyaloid can be observed, or heavens are not going to fall if you follow this patient. So if a hemorrhage is like this, a small, thin hemorrhage, anti-VEGF injection alone may work. But if it is a moderate degree, slightly thicker, then you have to depend on gas injection, pneumodisplacement plus anti-VEGF injections. But if it's a massive kind of subretinal hemorrhage, so you do a vitrectomy, hyaloid peel, subretinal RTPA, gas injection, and anti-VEGF. And if we follow this kind of regimen, a lot of these patients recover useful kind of vision. So thank you very much for allowing me to present this scenario. We try to do in the same sitting itself if patient is, you see, normally one day patient may take to decide, but this large doctor we intervene the same day. Yeah. Yeah, it's basically counseling, and patient has to financial arrangement that we go inside immediately.
So, what about the 40 gauge cannula when you for injecting TPA? You don't need to laser that.
No,
You don't need to.
yeah, because the opening is so thin
Yes.
that especially in the posterior pole, it does not require.
And you
laser.
just inject at the most elevated point
Yes.
on the
Absolutely.
macula.
Correct. The most elevated part, but you can't inject only in one part because it's a multilocular hemorrhage, and you can't expect this RTPA to permeate all the way. So
You did not experience any problems afterwards from the entry of that cannula. Later on the OCTs and everything, it was fine.
no, not at all.
So any more questions? Any more comments, please?
Yes,
Please go. Can you have this the mic? There's a mic over there, Doctor Saab. There's a mic over there. There's a station.
In case of injecting the C3F8 gas, would you explain, would you look for the PVD, whether is there any difference in cases in which the PVD is present or the cases in which the PVD
Can you
is not there?
move closer to the mic?
No, in where we are depending only on pneumodisplacement, we do not actually bother whether PVD is there or not. But we do paracentesis for these patients so as to allow 0.3 cc or 0.5 cc of gas to go inside. But that's a very relevant point of PVD. If PVD is there, then we are pretty safe. But if not there, it may get induced sometimes, or it may be partial PVD, or it may have some complications because of usual complication of PVD, like hemorrhage or tear formation can occur. But you see, if you think only in PVD patient, then you have to go inside invasive. So, but we follow this patient. But fortunately, none of our patients had required a vitrectomy after pneumodisplacement.
And so if the patient comes to us after, suppose in 1 week or 1 to 2 weeks after hemorrhage, then how do you decide whether it is, how do you know before going in whether it is clotted blood, we should go for pneumodisplacement or we should go for injection alone? If the patient comes late, then you would decide for pneumatic displacement or going for full vitrectomy and subretinal TPA.
So size of the hemorrhage will tell. If the hemorrhage is say more than 1 week duration, and even if it is the scenario number 2, we'll still counsel him for RTPA because that may help to dissolve the blood. The fresh hemorrhage, that patient came within 2 days, so therefore we thought that this may get displaced. So blood has to be liquid enough to get displaced.
So 48 hours is the cutoff.
Yeah,
time.
that's what I
48
take.
hours.
Yeah.
And if you go for pneumatic displacement, you use 100% of C3F8
Yes.
or SF6?
Yes. Directly from the vial.
100%.
Yes.
And how much volume?
0.3 to 0.5. 0.3 is the usual volume we
For
inject.
both C3F8 or SF6? Any type of gas or?
SF6 I have not injected. Generally availability in our center is C3F8 only.
C3F8.
But SF6 also can be injected.
Okay. Thank you.
There the volume will be slightly higher.
I think the idea is just the same as a pneumatic retinopathy, the same. You can't give more volume because it will ultimately expand if you give more volume to that. So I think now we will have our next talk then. I think Dr. Lalit will continue with his talk on macular holes, updates on macular holes.
Can you put it on? So this again is not my talk, but I dug out some slides of macular hole, and the chairperson asked me in case I can do that. So again, thank you very much for allowing me to share with you.
We want, we want, we want to have full advantage of your time since you are here.
So OCT is one investigative tool without which no retina practice can survive. In fact, I would go on to say even comprehensive ophthalmology should have an OCT because a lot of things get missed out otherwise. So on OCT, we normally ask our residents how many layers can you see here and which is which layer. And you can divide the pathologies on OCT into inner retina, outer retina. Inner retina is basically from ILM, which is here, to this green colored, this is ERM. So anything pathology here is in inner retinal pathology. And from this external limiting membrane to RPE, this is outer retina. So pathology in outer retina basically include ARMD, central serous choroidopathy and such things. Inner retina basically means diabetic retinopathy or vascular block, such things. And therefore, we are not very happy to see once a patient is prescription, say edema plus anti-VEGF injection. So if you study layer by layer OCT, then you will never miss any pathology. But I'm not going to talk about any of the inner retinal pathology, neither the outer retinal pathology. But we will talk of what is the junction where the vitreous meets the retina, and this is junction which is known as interface kind of pathologies. Remember, all of us are born with a gel vitreous. Gel vitreous means consistency of a lacy like white of an egg. That's a lacy substance. All of us are born like this, and this gel is adherent to the ILM at various places in the retina. What happens with age and other diseases like trauma, diabetes, and other things? Two things normally occur. One is the vitreous gel becomes sol. That means jelly consistency goes into solution. Second is this adhesion of the vitreous to the ILM decreases with time. So and if this liquefaction as well as adhesion occur completely, then you get a total PVD. Then F and F may occur, flashy and floaters may occur. And in this process, sometimes you may have a bleed or you may have a HST formation. However, if liquefaction occurs, but the adhesion is still there, not complete, then this allows the liquid vitreous to seep behind the hyaloid. And this initiates the process of PVD. It's not a total PVD, it's a partial PVD. And this is the stimulus for cells to proliferate. These cells proliferate and then there is a membrane formation. So this is what is known as anomalous PVD or an incomplete PVD. And this explains all the VMT disorders or the vitreomacular traction kind of disorders. So there are various disorders in the interface like VMA, VMT, ERM, and macular hole. So this was the latest classification of international classification of VMA, VMT, and macular hole, and this has been correlated with the GAS classification given a couple of decades back. The reason I'm showing this macular hole classification is they say small macular hole is 250, medium is 400, and large is 400 plus. But honestly speaking, in our practice, we rarely get such holes. We get holes of the size of 1000 microns or XL or XXL. Like we have out, t-shirts, you go to the market, buy XL t-shirt or XXL. So that's the kind of macular hole we get. We do not get L kind of macular hole. Neither we get S or M. So various, surgeries have been described right from the day when macular hole was first diagnosed. People started buckling, pneumo procedures, lasers. But all this above 3, they have virtually vanished. Macular buckle, some people do in a highly myopic eye. But what has stood the test of time is the vitrectomy. So first description of macular hole was long time back, 1871. It took more than 100 years for first surgery. That was by Kelly and Wendell, who reported vitrectomy with the gas. At that time, the role of ILM was not there. People did not have OCT also. So the success rate at that time was nearly 40 to 50% only. And since that time, since the time of Kelly and Mendel, a lot of modifications have occurred. Aim has been to close the macular hole and also to increase the comfort of the patient. So a lot of things have been tried, right from biological adjuvants, pharmacology adjuvants, and air injection also, but none of them have had acceptance. So therefore, I have written here limited acceptance. But what had stood the test of time is the ILM peel. Once this ILM peel came, then the success rate immediately jumped into 90s rather than 50s. So this is the first. This is one of the first surgery where we have done the hyaloid peeling, and after that we inject this BBG dye, or what's also known as blue ICG dye, and then with the help, aim is to find out an edge. You can use various instrumentations. Diamond duster is one. Normally we prefer pinch and peel technique. Directly, with the help of Eckhart forceps, directly pinch here. Some degree of small hemorrhages may occur, but this is of no concern at all. So in the first go itself, we are taking this flap across the macular hole. Notice what has been done here is that once we started with the flap, this flap is taken across the macular hole like this. So this is what is ILM peeling. And in the first instance itself, we try to peel as much as possible. Although people say size of the peel does not matter, but we normally in the first sitting take it arcade to arcade kind of ILM peel. And this is the patient, which is pre-operative, and this is the post-operative. And this you show the full thickness macular hole, and post-operatively has a good foveal contour restoration. Another patient, although PVD was present beforehand also, but this patient, this is the pre-op and this is the post-op, type 1 kind of closure we could achieve with membrane ICG peel itself. But a lot of new things have developed after this classic ILM peel was described. What has been described now is that duration of tamponade no longer we require for weeks. In fact, for 1 or 2 days, 3 days is good enough. That is the beauty of OCT. OCT has taught us that within 24 to 48 hours, most of the holes will close. And attention is also focused on smaller gauge instruments like 25, 27 gauge, and a lot of other things like ILM flap surgery or retinal tissue or even lens capsule or human amniotic membrane are being used to close the macular hole. So this was the one conference which I attended way back in 2016, where I heard about the flap for the first time. And a lot of things, in fact, in this ASRS conference, there are one hall devoted only to flap surgery. And this was a gentleman whom we interacted, Mike Leska, who described a series of patients of ILM flap surgery. So this was my first patient where I did a flap surgery. This lady I had followed up for more than 14 years when I was in a government hospital, now in practice. So this whole diameter was 1400 microns. So I offered this surgery, although she was reluctant, but somehow ultimately agreed for this surgery. And this is the surgery which I did after coming back from ASRS. You see similar technique like peel the first take of care of the hyaloid, then direct pinch and peel technique, try to initiate a nick in the ILM, and once you see the nick, now instead of taking it across, just leave it at the edge. Just leave it at the edge and go all across like a cabbage or a cauliflower. You have a multi-layered kind of ILM flap. The only difference here is that instead of taking it across the macular hole, you just have multi-layered flap, which is, like this at the end of it. And rest of the ILM, you can, peel it. But this is known as the ILM flap. There are a lot of variations of this. Some people have only temporal, some people have nasal flap. You can reduce the size of the flap by lowering the suction rate to 50 and highest possible cut rate. And then you do an electro exchange. So you notice this 1467 was the diameter pre-operatively, and this is the post-operative macular hole. You can see the remnants of the ILM at the surface here. These are the remnants of the ILM which you can see. So a lot of these patients have type 1 kind of closure. One of the main prognostic factors, this is again a macular hole 1116, more than 1000 microns, and you see post-operative picture, a type 1 kind of hole closure. This is that same lady which I had shown. This 15 years back, although we had diagnosed, and again macular hole did close. This lady till today has 6 by 12 kind of vision. So macular surgery is a reasonably successful surgery. Success rates are more than 90-95%, but sometimes it can, have failure also. So this was one patient who had the macular hole did not close. So what we did in this patient was that we raised a ILM graft. ILM graft was raised from the extramacular area. So this is the ILM graft being raised from the inferior part. And this ILM graft, once you have initiated this and raised of sufficient size, then you inject perfluorocarbon liquid. Perfluorocarbon liquid is required because you want to move this flap towards the macular hole. You cannot hold it with forceps and do it because otherwise, because the fluidics of the machine, this will keep moving. So this, once you injected PFCL, with the help of a diamond induster again, you move this flap. Under the weight of PFCL, this will not move now. So we are just, grazing, and this will settle here on this macular hole. And once you have done this, then you do a fluid exchange from the nasal side so that this flap does not move. Sometimes you can inject a drop of viscoat over it or any methyl cellulose. So the world is divided between peelers and non-peelers. Peelers for small macular hole and flap for larger kind of macular holes. So patients who have, like in the yellow box I have written, large macular holes, chronic macular holes, or persistent or reopened kind of macular holes, or macular hole in a myopia, so flap surgery is more preferable. So what has more recently happened, although success rate has improved dramatically, and even with the coming of this flap, you see 2 lines improvement in more than 70% of these patients. But patients who are highly myopic or who have diameter more than 500, this success rate is not as great. So therefore, as I told, Mike Leska came out with flap, and here the success rate improved by 10% or so. And this was the meta-analysis regarding the flap, which was presented a couple of years back. So despite peel, despite flap, still large macular holes or atypical still may be a challenge. May still be a challenge. So this was the Manchester Large Macular Hole Study Group, which I came to know. I thought I'll share. So people have used variations in the ILM flap technique, that they use PFO as I had shown, or people have this superior flaps inverted and they use visco to stabilize this, or extra large macular hole like 750 kind of macular holes. Such patients, they benefit from human amniotic membrane graft or autologous retinal transplant, or sometimes macular hydrodissection. Hydrodissection means that you create a detachment over the posterior pole, because sometimes this flap the hole may lose elasticity. So to increase that, you free the edge of the hole by creating a RD at that area. So this was one of the recent then I encountered. I thought that I had coined this term of XL and XSL, but this closed study group already have started publishing this XL and XL macular hole. And they analyzed the data of these adjuvant techniques in large macular holes, and they came out with a success rate of, with only in large macular holes, with human amniotic membrane 100% success rate, and with the autologous retinal transplant around 90-95%. So what they have said is that ART has a better visual prognosis compared to HAM. This slide just shows that as the size of the macular increases, the height decreases. So as the size increases, height decreases, and that is one of the poor prognostic factor for. So you see here the height is much more, size is less. In lower part, the size is now much more 1000, but the height decreases. So always you have to correlate height versus the basal diameter. So this is what I was trying to initially tell you: small, medium, large. Now people are scientifically using XL and XXL and giant macular holes also. And definition practically means this one, up to small macular holes, you can do only ILM peel. But between 400 to 600, ILM flap gives the best result. But once it crosses 700 to 800, then ART or HAM or combination of these techniques have to be done. Although I have done only one ART, I do not have any experience of amniotic membrane graft because did not find the need for that. So this is the current scenario world over which is followed for successful macular hole surgery. So thus to conclude, you see OCT and a lot of these newer theories of anomalous PVD have helped us in better understanding of the pathogenesis and the closure rate of macular hole, and the success rate with the newer techniques like flap, ART and HM continue to improve to nearly 95% or so. So thank you very much for again listening to me.
Thank you very much. Very nice presentation. Any questions, queries, comments, please? There is a lot of literature about this amniotic membrane closures, of all the agents used, I think it has shown better results.
Yeah, you see, anatomically, yes, functionally, slightly inferior to ART because you are using amniotic membrane, and Egyptian groups have shown that if you use ART, in fact, Dr. Mahmood from there uses ART as the first choice of macular hole surgery because he says that neurosensory graft you take from the superior retina and put it on the macular hole. So this amalgamates or gels with that tissue better than HAM, amniotic membrane. Although anatomically you are right, the success rate may be better, but functional outcome is slightly better in ART.
Okay. So any more? Yes, please.
Thank you for the wonderful presentation. My question is regarding vitreomacular traction in a patient who's got VMT and the visual acuity has deteriorated to 6/9 or 6/12 and we do see macular fluid. How long do you think it's all right to wait for the VMT to resolve since we do not have Jetria available in Pakistan? So what is that time threshold where you just want to intervene and go in for surgery in a VMT patient?
Yeah, VMT is, you are very, very appropriate question. VMT, I will wait for till the patient begs for surgery because VMT surgery is more difficult compared to macular hole surgery because you can induce a iatrogenic macular hole there. So Jetria came with a big bang, but the cost of Jetria is $4,000 and success rate is 26% only. So therefore, anything you inject in the vitreous cavity, whether it's air or fluid, that can induce a PVD. So aim of Jetria is an enzymatic, zonal lysis which it causes, but it's not, even if in the West it has been given up. People do not rely on Jetria. But the question what you asked is either patient should have a troublesome kind of metamorphopsia. Metamorphopsia, normally I ask the patient, kitna taklif kitna? If he says occasional metamorphopsia hota kabhi kabhi, then I will wait. If he says his life is hell, then I will operate at 6/9 also. But if not, then I will, as I said, I will wait till the time patient begs for surgery. Nahi, Dr. Sahab karo, nahi to meri zindagi kharab ho raha hai. So that is the answer because the reason is that I will show one video of VMT where, in such situations, you go round and round rather than pulling on the, you do a foveal sparing kind of PVD induction rather than, if you pull it directly, there's a high chance of iatrogenic macular hole formation. So two things we have to remember. What I do in practice is metamorphopsia, which is troubling the patient, and secondly, that patient has to virtually beg for that.
I would recommend you must take a video consent from the patient because they always refuse afterwards. But there's that before in those situations. Just I wanted to share
whatever consent you take, you see, in our part of the world, it does not matter because once the patient goes under the table, he is expecting good result.
Yes, especially in our part of the world, they are always. Yes, Dr. Sahab.
We are facing a dilemma in diabetic patient, diabetic macular edema having epiretinal membranes. So it is very hard to decide whether to go for injection or whether to go for peel and ERM plus ILM peel. So how do you decide whether this patient needs injection? There is a significant thick ERM and along with macular edema. So how should we decide?
So my practice, only what I do is I will try 1 or 2 injections first, because I have photographs which, if time permits, I'll show that these patients have responded to 1 or 2 injections of ranibizumab. If not, then vision has to be significantly low for me to go inside and to peel off the epiretinal membrane.
So in those cases, you also peel ILM or only the ERM?
We do try, but do not insist. We do try, but diabetic ILMs behave differently than macular hole ILMs.
Yes, that's why I
So we do try. They may not come in single piece. They may come in piecemeal, but we don't make it an ego issue that ILM nikalna hi hai. It's not mandatory.
No. Thank you.
Just, I'll share one. My patient, he came with a full thickness macular hole and recent PVD. So surgery was advised to him, but somehow he was reluctant for the surgery. And I think after 6 weeks he came to me with and we did a repeat OCT, and there was spontaneous closure of the hole, and his vision was, and the hole was continuing to get close, and his vision was 612 on that day. And later on, after 2 months, the PVD, which was already there, after 2 months or 3 months, his vision was back to 6/9, and the hole was totally closed. And I'm following him from, I think 1 year now. His hole is closed. So there is a existence of a spontaneous closure as well. Probably in this case, the PVD was recent, and there was some time was there, and after some time, without any medication except the non-steroidal those NSAIDs, he had this closure of the hole.
Yes, spontaneous closure of the hole I have also observed in a couple of patients, especially if they are traumatic, and especially if they are size of say 200-300 microns, they can close spontaneously.
Yes. But this possibility is only when the patient refuses surgery, probably. You can't, or when he comes with good vision, or probably perhaps in some stage 3 macular hole with recent, I mean, it's very difficult to decide which one to go for surgery side and which one to wait. The patient sometimes is reluctant for surgery. That is the only pathway.
So answer to this is, patient has to ask for surgery. We should not motivate the patient too much.
Yes. So I think with this we move on to the next talk. That would be on epiretinal membranes.
So now I will talk of my original talk, which I was supposed to present. That is the ERM. I bring greetings from this land of Taj Mahal, and whenever you please come to Delhi, please visit this very UNESCO protected monument, Taj Mahal. So thanks to all these dignitaries for having me here. So we'll talk of epiretinal membrane. Again, this falls into the category of those interface disorders. And remember, these interface disorders, VMA, VMT, here the membrane responsible is hyaloid. And in ERM, membrane is upon the retina. Epi means upon, so upon the retina. In macular hole, it is the ILM. So 3 membranes and 3 dyes are there. For hyaloid, we use triamcinolone. For epiretinal membrane, we use trypan blue. And for ILM, we use BBG dye. So on OCT, we can generally distinguish between a pseudo-color greenish hyaloid vis-a-vis a more reflective membrane, which is the red color, which is the epiretinal membrane. And again, coming to madam, what she was asking, all membranes don't require surgery at all. Like this patient has 6/12 vision, no metamorphosia, so no way to interfere in such patient. So 10 months, so many follow-up has been done, stable ERM, good vision, no complaint, we will not. Again, this is 6/9. This is 6/9 left eye. You can see the date also here, asymptomatic, although this does show, but patient has 6/9, so no reason to go inside. So indications for interference or going inside is, as I said, disturbing metamorphosia. Patient is disturbed, or vision has gone down significantly, not like 6/9, or there is associated hole or detachment. Otherwise, you see, we should not be showing our surgical skills, surgical heroism, that मैंने membrane तो निकाल दिया, but patient की vision कम हो गया. That should not be done. So I'll just show in one video itself a couple of, this is one membrane which we had done more than 15 years back. You see, hyaloid has been taken care of. Then with trypan blue, we stained this membrane, and with the bent, MVR blade itself, Aim is to identify the edge. Edge identification, after that you can, peel it off. Most of the membranes will come in a single sheet itself. Unlike hyaloid, these membranes may not have a second layer. So this will come in a single sheet. So our aim should be to keep an eye on the underlying retina. And in that process, don't, damage that. And this membrane generally comes in one go itself. This is one diabetic patient where there was epiretinal membrane, and one of our fellows were trying to show his skills by not staining it, and using directly. And you see the difficulty was that ultimately what was being removed was not very clear. So normally we prefer to stain these membranes so as to be very sure that what you are doing. So this is again another diabetic. So this was a proliferative diabetic retinopathy, but these membranes are epiretinal membranes, and this you can, depending on the adhesion to the underlying retina, you can use only the cutter or combination of cutter suction or sometimes the retinal spatula also to tease away these epiretinal membranes from the surface of, and never allow this iatrogenic blood to accumulate for a long time. And then once the edge is found, then you can take a forceps and peel away this diabetic membrane very nicely. So this was about the diabetic membrane. This was one patient where high myopia, where I had done the RD surgery, but post RD, under the oil, this patient had a epiretinal membrane. So this can happen post VR surgery, vitreoretinal surgery also. So you can, under the oil itself, you can take hold of this forceps and identify the edge. And once you catch hold of the edge, if you want to retain the oil, it's okay. Otherwise, you can remove the oil if the purpose of the oil has been served. This was one patient who had ARMD also. If you notice, this patient had some this has some macular colloids along with it. So we start the surgery with core vitrectomy. After that, inject a few crystals of triamcinolone. Triamcinolone gets adsorbed onto the surface of vitreous fibrils. And after that, I like to dry the retina with air phase change. The posterior pole becomes absolutely dry with the help of this back flush needle. And once it is completely dry, then 1 or 2 drops of reti blue or trypan blue, we inject over the posterior pole like this under the air, and wait for 2 minutes or so. And after waiting for some time, then under the air itself, try to get this excess of trypan blue out. This excess trypan blue is being aspirated passively with the help of backflash needle. And once this is taken out, you will see a nicely stained epiretinal membrane at the posterior pole. This time you turn on the fluid, and once the fluid is turned on, you see this nicely stained epiretinal membrane. And the favorite instrument, my favorite instrument is a MVR blade, an old MVR blade, because old MVR blade will have some kind of, old MVR blade has the property to have some kind of tip here. If the tip is here, then this serves as a pick. So edge gets identified, and then hold the membrane, then go to the base again. Don't keep pulling at the tip itself. Go to the base again. Try to loosen this adhesion between the retina and the ERM, and then take it all along the surface of retina. And this comes in single go, a big epiretinal membrane. This is another patient who has a large epiretinal membrane. You see the size of the epiretinal membrane is so big. Again, with MVR blade, pent MVR blade, you identify the edge and take this end opening forceps, and after teasing it, go again to the base. Don't keep pulling at the tip. So we leave this here and then go to the base again, so as to have a firm grip, because these membranes are thicker at the base and thinner at the tips. This patient has had multiple surgeries. Some part of PFCL is under the retina here. A huge membrane comes out. You see the size of the membrane generally more than what is visible. A huge membrane. This is a young patient of Behçet's disease actually. You see all the vessels are closed here. He had urethritis also. A thick, very thick epiretinal membrane is here. So this membrane, apart from being extensive, is stuck very badly with a cord-like structure at the disc. So here aim was to just trim it here rather than, because if I pull this cord, maybe I would precipitate some bleeding here. So I just, trimmed it till the optic nerve and ultimately left it there itself. So whatever was trimmable, we trimmed that. Because if you pull too much, it may precipitate bleeding also. And then laser this patient. This is another patient who has had a thick epidermal membrane OCT. So we begin with core vitrectomy, triamcinolone assisted hyaloid removal. And once this has been done, dry the posterior pole. And after the posterior pole is dry, with the help of backflash needle, put 2-3 drops of trypan blue. Aim is to stain under the ear itself. This is 2-3 drops of trypan blue which are injected on the posterior pole. Then wait for 2 minutes, take out the excess trypan blue from the posterior pole, and then you have this nicely stained epidermal membrane. With MVR blade, identify the edge. And once this edge is identified, take hold of forceps. And once I was pulling, what I found different in this patient was the amount of pull either was more or this adherence was more. Because once we are taking this membrane, you see this whitish discoloration of the underlying retina. So that is the moment you should stop. Because if you pull too much, you see this, we are pulling, but see the underlying retina. So what we did differently in this patient was, we made a cauliflower like, you see the underlying retina. So at that time you may have some palpitations, kahin retina phat to nahi jayega yahan se. So therefore you go round and round. Maybe this will loosen the tissue. And then actually I resorted to cutter and remove this membrane. The aim was not to, like madam was asking about the iatrogenic issues, like hold it here because this is badly stuck here. So get this cutter, because this will, even if a small remnant is left there, does not matter. You can leave that small tuft there also. So this is another patient who has had all the components. He has a lamellar macular hole, he has a epidermal membrane. So what we did was 4-in-1 surgery in this patient. We did a cataract surgery, we did hyaloid, we did ILM, we did ERM also. So this was this lady who had all the ingredients of all BMT disorders. So this is the PHF getting removed with the help of transferon assisted vitrectomy. And then normally I do an airflow exchange and make the posterior pole dry, and then put 1 or 2 drops of trypan blue. Wait for 2-3 minutes, remove the excess trypan blue with the help of passive egress of through backflash, and then with the help of MVR, identify the edge. And this edge was not so easy compared to others, but we removed this huge epidermal membrane from arcade to arcade or even beyond. But there was a lamellar macular hole also. And once this, the trypan blue did its job and this epidermal membrane came off in a single sheet, then the third dye comes in, that is the BBG. So this the BBG was injected under fluid itself. And then this is the ILM getting removed now. The previous blue membrane was epidermal membrane, this is the ILM now, which is getting removed. Again, you see nicely stained. The purpose of staining agents is to make your job precise. Then you will cause less of complications. Otherwise, you can do without that also if you are very confident. But this entire ILM then comes out. So all the 3 membranes with 3 different dyes have been taken care of. And then you do airflow exchange and gas injection. IUL was also done in the same city. So this was the result of this patient. Started with this kind of foveal contour, 624 vision, and finally after a few months, it takes a couple of months for foveal contour to come. Metamorphopsia may go within a couple of weeks, but contour will take a long time to come. For that, you have to keep counseling the patient that it will take some time. Fortunately, because of the health of this ISOS junction, the vision recovered to 6/6 in this patient. So ILM was being asked there whether we remove ILM. I do try in all patients, but I do not persist. not at the cost of damaging. And remember, ILM is a part of retina. ILM is not a innocuous structure. All of us have become ILM addicts, that we want to remove ILM in all the patients, but that is not necessarily required. And global trends in retina survey, ASRS survey also said that ILM peel in ERM surgery is not advantageous from the point of view of vision. So we should not insist for our ego. So just to summarize again, that 3 membranes and 3 dyes, PHF, triamcinolone, epiretinal membrane, trypan blue, and ILM BBG dye. And this makes the job precise and helps to salvage a lot of these eyes. So ERM is a fairly common VR disorder. Diagnosis is not difficult at all. Most important is all ERMs do not require surgery. And surgery is not difficult. Finding a plane is the key step. Once you find a plane, and during surgery, staining definitely helps. And ILM peel, as I said, is not a must. Results, metamorphosis improves in a couple of days or weeks, but vision improvement and OCT improvement sometimes takes longer time, may take months also. So thank you very much again for patient listening.
Thank you very much. Do you have any experience of using intraoperative OCT in those cases?
No, I do not have that. Would love to have that. But I have seen a lot of videos of my colleagues who have intraoperative OCT.
Does it add any advantage to this type of surgery, or?
They say, people who have it, they say yes. People who don't have it, I don't feel the absence of intra, because I feel that it may be distracting also. Although there are 2 types of intraop OCT available, they say, but it definitely helps where you are in doubt. If you are in doubt, then you can flip it on and see, are you in the right plane or not.
So any more questions from the audience? Otherwise, we will end the session before time then. Is Dr. Ali Zain here? I don't see him. Any more questions, or any other question you would like to discuss or ask from the? So in that case, we will thank you very much. You're very kind to come here and in such difficult situation of the visa problems. Thank you very much.
Thank you so much.